Welcome to the WOVA Circle, real talk on fertility, wellness, and trying to conceive. I'm Gabby Paychev, founder of WOVA Health and fertility educator. This podcast is your community space for navigating the path to parenthood with evidence-based insights, authentic conversations, and genuine support. I'm dedicated to being here with you through every part of your journey. Dr. T, it's so good to have you back.
Yeah, thank you so much, Gabby.
So I'm gonna dive in with some of the questions I received.
For sure.
And the first one is, what types of pelvic conditions can be assessed or diagnosed virtually? How can someone who's trying to conceive still benefit from online sessions?
Yeah, I think that there can be a lot of conditions that can be treated virtually. The beauty of virtual sessions is that they are in the privacy of their own home. And with some of the things that I might do in person, they can be able to do some of those on their own. I could still be able to communicate and talk with them, but they can at least turn the video off. So if there's like certain parts of the assessments that they want to do in private, but at least in regards to conditions, it really could be a number of different things. So if they're experiencing any type of pelvic floor dysfunction, which can consist of any type of pain, if they're experiencing incontinence, so that can be urinary or fecal leakage. I see a broad range of patients, whether it's from preconception all the way through postpartum. So even if I'm working with a postpartum patient and they're experiencing pelvic pain or diastasis recti, or if someone has just had any type of pelvic surgery or abdominal surgery, which can be a C-section, it can be a laparoscopic procedure after having excision surgery, addressing like any scar tissue issues, and I can help teach them how to do scar tissue remediation work as well. So there's several different types of pelvic conditions that I can see patients virtually, and I can walk them through at least how to assess what's going on and maybe even address exercises or manual therapy treatments. But if it ends up becoming a point where they're working on some of the things and they're experiencing more pain, they're experiencing more symptoms, then it would be really beneficial for them to come in person. Ideally, I'd like to see them for the initial session first so that I can do the assessment, especially if someone isn't very in tune with their body and able to really assess, is this way or that way, where their pain level is, or even just like touching themselves. I would like to at least be able to do that evaluation first, and then any follow-up visits can be done virtually.
What are some limitations of virtual consultations when it comes to pelvic floor therapy?
If the person isn't very in tune with their body and I'm not present and able to work with them physically, I would say that's going to be one of the biggest limitations, especially when it comes to pelvic pain. And if it's chronic and they've been dealing with that for a really long time, there's already like a stigma or a blockage of them wanting to address that pain themselves because they're afraid of making it worse. Or if they've had regular flare-ups, then if they're not as in tune with their body or regularly touching themselves or doing massage or whatever that thing is, and then if I'm asking them to do that without really them having much experience with that, they're going to be afraid of having a flare-up. And they might not then do the thing that I'm asking them to do. It might not be as effective or impactful. So I would say that would be one of the biggest downsides of virtual sessions. I think just having that physical touch is going to be one of the biggest factors.
Thank you.
Yeah.
When is internal pelvic floor work necessary versus external?
I think internal pelvic floor work can be beneficial across the board. I don't want to say that it's not necessary because I think it can be necessary just to have a baseline, just to have an understanding of where is the person starting from in addressing that particular issue or condition. So even if there is already like some hesitancy around doing pelvic floor work, if I can at least on the first or the second session do some type of internal assessment and establish a baseline, and then we may never go back to that again. A lot of it's really dependent on what that patient, what they want and their desires. There's a lot that I can do externally. So whether that is actually externally on like the perineum, on the outer labia, the vulva, around the anus, on the pubic bone, around the sacrum, the sits bones. So there's a lot that I can do externally, working with the pelvic bones, working with the pubic bone, the sacrum, the tailbone. I do a lot of visceral work as well. Mobilization of the organs, how the ligaments attach into that abdominal or pelvic cavity. So I can address the bladder, the uterus, the rectum. I can do all of that externally through visceral mobilization. And that's a really great way of being able to address any asymmetries or dysfunctions that are present that might be harder to address internally. There are benefits to both, but I think if someone is coming to me with specifically pelvic floor condition, it's really helpful to at least address the pelvic floor internally and get a picture of what's going on. And then I'll work externally on all of the things that I think may be implicated. And then halfway through the session or through the plan of care, or as we get closer to the end, especially if they're experiencing an improvement in their symptoms and they're progressing, then we might do a reassessment just to see, okay, are things different from when we originally did the assessment?
So for someone who's trying to conceive, the first time you see them, what would be the best type of assessment to do? What questions would you ask?
A lot of it would be just how long they've been trying to conceive. Have they actually been successful in conceiving? Because again, there are those who are trying to conceive and they are able to, but then have early losses. And so when they are having the losses, is it after a couple of weeks? Is it a chemical pregnancy? If they have tried to conceive, is it an ectopic? Just what their experience has been. And also who they're working with as well. That's going to be also just like a really big thing. Are they working with a reproductive endocrinologist? Or are they working with their OBGYN, an acupuncturist, a body worker, just so I can get a sense as to who is their team? What does that look like? So I can see, are they wanting to take more of a really conservative approach or using more Western medicine or more complementary alternative medicine as well, or if they're looking to be just like really integrative. Those are the questions that I ask. Because trying to conceive is more than just like a physical aspect, it's also looking at their mental health and also their emotional, and even though I'm not a therapist, but because they're spending 75 minutes with me and I'm doing a lot of work with them, especially when it comes to their abdomen or their pelvis, that it can bring up a lot of emotions. So I'm going to ask, are you working with a mental health therapist? What are things that you're doing in order to address the stress of trying to conceive? What does that look like? How are you caring for yourself? So those are other questions that I would ask. And then beyond that, then the basic, just have they done a hormone panel? Have they done testing for their thyroid? Just so I can get a sense as to what their overall health is. And then specific to their pelvic floor, are they one to experience pain with intercourse? And then to be a little bit more specific, do they have pain with insertion? Are they having pain with more penetration? Are they having any issues with their bowel or bladder? Because all of those can also have an impact, especially if they're having some issues with their uterus. Any surgeries that they've had. And when I say surgeries, that's really even from a baby to a little kid. Because there are babies or children who have some type of surgery like a hernia, or there was like a kidney condition that they had as a little kid and they had surgery. And all of that can have a huge impact 20, 30 years down the road when they are actually trying to conceive. So it's nice to get a sense as to what their surgical history is as well.
That's a good point. So you're not looking at just their recent surgery history.
Absolutely. And then even same thing with, have they been involved in motor vehicle accidents? If they were an athlete, did they have a lot of falls? If they fell on their tailbone, if they fell on their pelvis, if they fell on their back, if they were an athlete or a runner, for example, or a soccer player, like a labral tear. Because if there's a labral tear that's present, that's already creating a lot of pain. It's going to create a lot of dysfunction in the hip, which is then going to affect how they're walking, how they're moving, how they're holding themselves, which will then also have an impact on their pelvic floor as well. And potentially, if they've fallen a lot, then even just, I think of it almost like a whiplash, but of the pelvis. That's enough to just jar those organs. I would say it's probably not the same impact as if it was like impact on the head and the neck, but that's, especially as a little kid and you're developing, that's enough to have some negative impact later on in life.
I love it. You're taking a really holistic approach.
Yeah, I absolutely have to. I'm working with them on improving their fertility, but then they're telling me about the back pain that they're having or about the indigestion issues and like their GERD or their IBS symptoms as well. How can you not say that's going to not have an impact? Or even if they do have the ability to conceive, but then what is that going to look like when they're pregnant? What is that going to look like during their whole pregnancy, during postpartum, the ability for them to be able to have a vaginal labor if that's what they're looking for? How can you not address that? You just have to, because overall, that's what's going to help to improve their quality of life. If they're able to have like regular healthy bowel movements, they're able to move and exercise, which all of those things are going to be important in order for them to be able to try to conceive. Yeah, it's important to be able to have that holistic approach with them.
So you mentioned when you're trying to conceive that it's not just about getting pregnant, obviously, because you want to optimize your health, your partner's health, and hopefully your kid is going to be much healthier. What are the most common pelvic dysfunctions in people who are trying to conceive? Maybe like the top 3, top 5.
I would say the biggest that I see is there's some level of pelvic floor tightness or tension. So that's one, which obviously is going to make it really difficult to then be able to actually have intercourse to be able to conceive. So that is one of them. But a lot of that can be due to whether it's like vulvodynia, vestibulodynia. So if there's some level of irritation, chronic irritation that's present in the vulva or in the vestibule. And then again, if I were to go like a deep dive, then a lot of that is, do they have a history of some type of bacterial infection, yeast infection, UTIs, which then have already created a whole host of already like chronic irritation around the vulva, around the vaginal opening, which then creates that tension, which then makes it really difficult to then be able to create softness and opening around the vaginal opening to be able to have intercourse. So I'd say that would be probably about the number one. Number two, I would say, is endometriosis is probably another really big one. So some of the folks who I've seen, generally they have gone through IVF or planning on doing IVF, but they've had some type of diagnosis of both endo as well as adenomyosis as well. And which just is just going to make it a lot more challenging depending on the level of or the stage of the endo, if they've had surgery to remove some of the endo lesions. Yeah, and then just the chronicity of it. So I'd say that would probably be the second most. And then the third category is really the one that's, they call it unexplained infertility. So there's no rhyme or reason as to why they're not able to conceive, especially if they've done all of the blood work, the hormone testing, and everything looks normal, quote unquote normal. However, what then I'm seeing, I would say it's almost probably more like mechanical infertility. So there's some dysfunction that is present in the mobility of the uterus or in the mobility of the ovaries, which then is not allowing for good blood flow, optimal circulation, and mobility of the physiologic function for those organs. And so those are things that are not going to be seen through an MRI or a CT scan or through a blood test. And generally when a doctor is like palpating the uterus, their job is to find any type of abnormality. to find if is there a fibroid, is there just like a thickness or hardness of the uterus, indicating potentially adenomyosis. But they're not feeling for what is the optimal mobility of the uterus. Does it have the ability to be able to move in 6 different directions? Unless if they're seeing that there's like potentially pelvic congestion syndrome and the person has like venous disorder, that might be something that they could see. It should also, I'll put this under also unexplained infertility, but also a tilted uterus as well. Because I will have a lot of patients who they've been diagnosed, they go in for their ultrasound, and the ultrasound tech or imaging person will say, oh yeah, you have a retroverted uterus or you have a tilted uterus. And it's seen, and it's seen as, oh, that's it. Okay, so I shouldn't be worried about it. It's like, yeah, you should be totally. I don't want to say to the patient, you should be worried about it, but yeah, this is of concern because if your pelvis is tilted or retroverted, yeah, that's going to make it a lot harder for you to conceive. And also, that's not an optimal position. It's possible. I have had patients who've been able to conceive with a retroverted uterus, but I think it definitely makes it much more challenging, and that's not the case for everybody because that's not the optimal position for the uterus inside of the pelvic cavity. So yeah, I would say like a lot of those cases, when I palpate someone's abdomen, and I always tell patients it should feel as if it's a pillow. So I press into the abdomen and it should feel soft. It should be compressible. Obviously around the uterus, yes, because it's a muscle, but everywhere around it, because the colon, the small intestine, large intestine, they're hollow. So I shouldn't be feeling any tension or tenderness, or there shouldn't be pain. The only like dense organs that I should really be feeling when I'm palpating the abdomen is going to be the liver and the uterus. Everything else is a hollow organ, and when I press into it, it should be able to compress and it shouldn't create any pain. And I remember one particular patient who was diagnosed with like unexplained infertility, and I pressed into her belly and I'm not even able to get like much depth in, and everything was hurting. And yeah, there's just so much tension. And so who knows whether is it abdominal tension? Is it tension because of pain that she's been holding? Has she been just unconsciously holding her abdomen for whatever reason? Because again, like I mentioned earlier, because of accident, injury, fall, surgeries, that there's tension or tightness because of scar tissue or just because of all this holding, because the body's looking to maintain some level of stability because of a fall from years ago. So it could be a lot of different issues, but it's important to be able to also assess that and assess the bones, assess the organs. Yeah, all of that. So I would say those are going to probably be like the 3 big things that are big conditions that I usually see for those who are experiencing infertility.
And all of them very common. My husband and I were diagnosed with unexplained infertility. Do
Yeah.
you also work with men, with the male partner, or mostly with women?
I haven't had any patients who request to have their male partner come in. I have had one patient who has been dealing with long-term difficulty with conceiving, going through IVF. Her partner, and she was also experiencing bouts of infections, and so it was being passed back and forth between her and her partner. Then her partner was experiencing pelvic pain for a period of time. Unfortunately, for most men, they're not as willing to, or at least I'm going to speak for this particular person, was not as willing to want to do the work in order to be able to adjust what was going on. I always recommend, especially because it's the women who are coming to me, ensuring that their partner is also getting their blood work done, they're getting those sperm testing, just to address their health as well. If they're wanting to take a deeper dive, they can come, whether it's work with me or work with another therapist. There are male pelvic PTs as well, if they feel much more comfortable to work with a man for their pelvic health. But I haven't worked with any men in my practice.
To know that pelvic health physical therapy can assist both partners.
Absolutely. Yeah, definitely. And
Okay.
just in the same way that the endocrinologist is going to recommend that their partner is also getting some blood work and their sperm tested, should be the same case to be able to see a pelvic PT.
It should be common sense, but as you said, a lot of time, I think the pressure falls on women. We
Definitely
think,
does.
okay, maybe the issue is with us, and we're a little more proactive oftentimes, not all the
Yeah,
time, but a little more proactive in terms of, okay, we need to figure out what's going on.
definitely.
But men should also do that assessment because it's obviously both partners are of equal importance here. So talking about trying to conceive, I want to jump into the Mercier therapy. I'm really
Yeah.
excited to talk about this one, or to actually hear you talk about this one.
Okay.
So can you tell me how it differs from traditional pelvic physical therapy and what
Mhm.
drew you personally to get trained in this method? I know not a lot of pelvic health physical therapists actually know it. You're one of the few. So would you tell us more about it?
Yeah. So I'm trying to think about just like when I first heard about Mercier Therapy. It was several years ago. I heard about Dr. Jennifer Mercier, and so she and her practice, they're based out in Illinois, so a little bit outside of the Chicago area.
Mm-hmm.
And luckily enough, I have a little sister who lives in Chicago. I signed up for her course while I was also visiting my sister, which was perfect because I was able to at least be able to do two of those things and attend her training, which consisted of learning the Mercier Therapy protocol and then also how to be able to offer it for those who are, because you can have it be just like a standalone, just doing the Mercier Therapy protocol, but then also having pretty much like a package of treatments to be able to address fertility. So then being able to discuss, as a physical therapist, I can't prescribe medication, but I can at least talk to the patient about, oh, these are supplements or things that you might consider taking, and talking with your primary doctor to ensure that there's no contraindications with any medication that they're taking. So it worked out for me to do that training. The other thing was also I was just 2 months fresh from having a loss. So it was like a 10-week loss. So also in that aspect, just even from having that loss and to be able to get that type of body work from others who were also learning was also great on my body. So I can actually feel just, oh, these are the benefits. This is how it's helping me care for my uterus and care for my body in a really great way. So that was my in. Before that, I had watched Mercier. Dr. Mercier has not a free, but it is like a small fee of like a video that you can purchase to be able to just hear about some of the research and just her approach towards this protocol that she's developed. And I would say like what makes Mercier therapy a little bit different than from traditional pelvic physical therapy is it is just like a set protocol where it is working, I would say, very intensively on mobilization of the uterus. So mobilization of the uterus as well as the ovaries. And the nice thing is that it's generally done for 6 consecutive sessions. And so I'm addressing ovarian as well as uterine mobilization. I'm also addressing soft tissue, so looking at their hip flexors and their iliacus and how that tension along that space can be impacting the mobility of the uterus. Just because the broad ligament, which is one of the ligaments that comes off of the uterus, just sits in that space of the pelvic cavity. And I'm also looking at mobility of their sacrum. I'm looking at their sacrotuberous ligaments, which are ligaments on the posterior or the back side of the pelvis that's maintaining stability. But if that is overly tight, then that can also compromise the ability for the sacrum to move. And why that's important is because the uterus also has ligaments on the back of the uterus attaching to the front of the sacrum. And so if the sacrum and the tailbone and the tissues surrounding the sacrum are really tight and they're bound down and don't have the ability to move, then that can also limit the ability for the uterus to move well. And sometimes that can also lead to all that tension to some of that retroverted or tilted uterus as well too. And I'm also working on the fascia as well. So I'm addressing any tension along the thoraco, the lumbar, as well as the sacral fascial area. And so there's some skin rolling or manual therapy techniques that I'm doing for all of those. So the only thing that's different is that there's no internal work that's done. So everything is external. So especially for someone who is wanting to address their fertility and they're wanting to really work with a very conservative approach, but they don't want to do any internal work, then this might be the route that they want to go. And usually I will do this with them and I'll say, okay, after doing an assessment, I'll work with the Mercier Therapy protocol and let them know, okay, let's see, does this change your periods, where your periods are like less painful, you're having a better flow, you're having less discomfort overall in your pelvis and in your body, or if you notice like an increase in like cervical mucus during ovulation. So all of those, it can definitely help with all of those things. But then if we're not seeing any improvement, then I would say, okay, then we need to just address what's happening internally.
When do you expect to see an improvement after a couple of sessions? Like when do you make that follow-up assessment?
Yeah, I think it's really dependent on each person. So a lot of it is going to be really dependent on just like how chronic the issue is. For some, it's pretty immediate. I would say like after 3 sessions, they will notice a difference. Like they're feeling better in their body. They're having less pain. If it falls within their next cycle, they'll notice that their cycle is like pain-free, or if they're close to ovulation, they'll notice, oh, I've actually have more cervical mucus than I did before. So I would say for some, it's pretty immediate. For others, it will take some time. Like I think there's pros and cons to doing the Mercier Therapy because it's the same protocol that's being provided, but it's not looking at the whole entire body. So that's why I do providing both Mercier Therapy as well as the pelvic PT component, because I can then at least look at that whole entire body, whereas the Mercier Therapy protocol, it's not going to look at what is the nerve tension from the cranium that's affecting the spinal dura all the way down into the sacrum and having an impact, where I can be able to do this protocol but then also address some other aspects of the body that are also needing attention as well. The other thing that I love about Mercier Therapy is that, yes, I felt more knowledge and information around supplements that can be helpful, that I can always make recommendations to patients that can help, whether it's just for regulating their mood, or especially if they're dealing with stress, they're having a hard time sleeping, that's going to have an impact on their fertility. So then at least being able to make some recommendations to be able to help them, especially if they don't really know, they're taking so many supplements and they don't really know which one they should prioritize. So I can at least be able to have conversations with them on that. Yeah, and then the other big piece of Mercier Therapy is really also that self-care piece. Yes, I'm working with them once a week, but then also there's an expectation that they're also doing work on themselves as well. Mercier Therapy is a really big proponent of doing some type of yin yoga, so addressing fascial tissue tension, having a regular practice of incorporating that mind-body connection as well. Also doing BBT charting too, because I've had some patients who've never done that before. BBT is like the basal body temperature, where you're taking the temperature every morning. And some people have never done that before, where I think is so important because it just gives a really great window into what is your fertility like day to day. It's your report card on your body. And then your period just really lets you know what's going on, whether you're having a really good month or not a great month.
You definitely learn there's so much you can do, so many tools, and so much knowledge you can utilize when you've been trying for some time.
Yeah.
And it's actually sometimes overwhelming, and it's great to talk to a professional or specialist like yourself who can direct them and who can make it more personalized, even with supplements, like what is the right dosage for you? What is the right supplement specifically for you or your partner?
Yeah.
What is the success rate of the Mercier Therapy? It was 83%.
Yes, so it's actually pretty high. Dr.
Yes.
Jennifer Mercier did a research on her own patients and then also on some other practitioners who have been doing this protocol. And even though it's a very small sample size compared to a lot of other big research that is usually being done that is obviously funded with a lot of money. But even with that small sample size, it was actually way more effective than IVF, where the percentage is like 20% of success rate. But then like after 3 or 4, I know like then after each successive IVF round, it becomes more successful, but it's still, then it's maybe like up to 40%, but that's still really low numbers after having to go through all of the medication, all of the shots, egg retrievals, and the expense as well too. So the expense of going through IVF and several rounds versus the cost is really minimal in comparison to IVF. The commitment's maybe a little bit more. It's asking also a lot more as well of that patient, because there's a certain level of change that has to occur, not just relying on the endocrinologist, the person to do the work for you. It's really on what can me as a person do, like self-care wise, addressing overall health, addressing stress, all those things in order to be able to help. And even if you are going to go the IVF route, that is just going to help those chances a lot more.
So instead of maybe doing 3 or 4, you would end up doing just 1.
Yeah.
And you might get pregnant naturally.
Absolutely. I've heard stories, and I've also had stories of those who go through Mercier Therapy. They're going through the protocol, or even all 6 of the protocols, and then they're about ready to go and do an IVF transfer, but they're still trying naturally, and then they're able to have a natural conception as well, which is great, because whatever it was that they were told of like unexplained infertility, the Mercier Therapy, and I would also say like in regards to just pelvic PT, are able to at least address what it is that is occurring, that they're able to then conceive naturally and just increase their chances a lot more than having to go the route of IVF.
This is obviously assuming that on the male side, things are fairly okay as well.
Yes, no,
So
absolutely.
it sounds like the Mercier Therapy needs to be done in person with some in-between sessions that you can do at home.
Yeah, so definitely in person. So it's not a virtual session, just because all of it is, it's all manual therapy, so it's all hands-on. And it's not something that I can teach you to do, because the level of pressure that needs to be applied for the uterine mobilization is fairly, you just can't apply that same type of pressure on yourself. Mm-hmm. But yeah, it's definitely beneficial to come in person for those sessions. So definitely not a virtual. However, like I said, so also because it is like 6 consecutive sessions, and then if the person is going through a trial of IVF, but they want to just prepare their body, they can do the 6 sessions, take a couple of months off, do all their practices in order to help to ensure that their body is staying healthy and active and mobile, and they can come in like once a month if they wanted to, in order just to make sure that things are just still staying, everything is optimal as much as possible.
Amazing. I love it. 83%.
Really high.
So for those who aren't in the San Francisco Bay Area and live in different states or different regions, and you can't really see them in person, are there any other certified Mercier Therapy specialists across the US that we can connect them with?
There are, yeah. So if you go onto their website, there is a directory of those practitioners who are still practicing. And so you can at least be able to see who is available in your area. I have had someone from like Sacramento, so it's like at least 2 hours away from Oakland, come, and then she would actually stay. So I think I would see her at least like twice a week. And I know Dr. Jennifer Mercier, because obviously she's the founder of the practice, she will have people like travel even from overseas and come and stay in the Chicago area for a period of time just to receive sessions from her. And then those are people like who might have tried everything. They've tried IVF, they've tried other IUIs and other approaches, and still nothing. And then they hear about Mercier Therapy and they're wanting to give it a try, and in a lot of cases they're usually pretty successful. Yeah, so a lot of yes, like I mentioned, it does take a level of commitment. And obviously, yeah, if you're in an area where there is someone who practices Mercier Therapy, then it'd be great for you to be able to just easily drive over. But if not, just to be able to at least reach out. And if you're flying or like me, so I'm visiting my sister and then just took the opportunity to be able to also do the training at the same time, which made it worthwhile. Yeah, and it's unfortunate just because, yeah, to be able to access a lot of these services, there aren't a lot of people who practice it, or even physical therapy as well too. Just like for pelvic PT, like that's also, in a way, hard to come by. The need is really high, but there just aren't enough practitioners. So I would say it's even the same thing as well too.
Well, thank you, Dr. Tia. Thank you so much. This was very,
Absolutely.
very helpful.
Cool. Thank you so much, Gabby.